All right. Honestly, this should be pretty easy and quick. Painless. I'm promising you, it's painless.
I don't know about that.
If you want to call me a liar, you can call me a liar.
I've tried to put some patients that have firing, defibrillating randomly. They seem pretty painful. So.
If you got an AICD that's not working and it's consistently defibrillating the patient, yeah, that's painful for the patient. I'm saying it's going to be painless for you. So these are terms that you need to know, and we'll talk about them through the lecture. If you guys want to tell you what they are right now, I can, but they'll make sense more in the lecture. All right? But it's good when you're studying, you can go back to this and just be able to check yourself and check your knowledge. So, pacemaker, the artificial pulse generator, delivers a current to make the heart depolarize, right? So there's a pulse generator, which is the power source, and pacing leads. Both are implanted in the body, usually under local anesthesia. They don't even need to put a patient out. Because once you get in the vessel, it's painless. There's no nerve endings or pain sensors within vessels. So it's just the initial poke and the initial, stuff that they do with the skin that's actually painful. Pacemaker wires are surrounded by plastic catheters. The circuitry is housed in titanium so that it's impermeable. So you're not mixing fluid with electricity, except at the electrode.
What kind of battery do they stick in? Is it like a watch?
I have no idea, but it lasts for freaking ever.
Power battery, Alex.
It's a lithium battery.
It's a hamster. Yeah.
How often do they need to replace
I assume that it is similar to like what you would see in a key fob in a car. Those batteries will last for years, right? I don't know. Mine sucks.
Mine sucks.
But this is a cardiac pacemaker, so it's going to be better than that. All right. There are better batteries than the ones you can buy at Walgreens. You just have to pay a lot more and get it from certain places.
That makes sense.
All right.
Moving on.
So temporary pacemakers. So you got transvenous pacemaker. I've only had to place one of those in my whole career, which I guess my career's not all that long. Epicardial pacing, I've done that as well, which is cool. You guys know what epicardial pacing is? If you think about it, it's when we've cut the chest open on a traumatic patient and we've cut open the pericardial sac and we're doing squeezing. And after you've cut the patient's chest open, it's not very easy to defibrillate them with normal pads anymore, right? So we get the little metal discs and we put them right on the heart. Epicardial pacing. And then, of course, your traditional transcutaneous pacing. What's that?
I said that's going to be a paramedic skill.
Yeah, that's something you're definitely going to be doing. All right. So unipolar is one electrode at the distal tip, and the negative electrode is in contact with the heart. The pulse generator is where the positive electrode is, or it functions as the positive electrode.
So there you can actually shut those the valve on the inside.
Not completely. Not completely. So yeah, there's sometimes some regurgitation. But those valves kind of adjust, right? So when they're in a closed position and that electrode's going through it, kind of folds around it. So even though there's still some regurgitation, it's not as much as you think. It's not like it's taking out a whole leaflet, you know? And likely if you're putting a pacemaker in somebody, their valves already kind of suck. But, so a bipolar, there's a positive and a negative electrode. It's on that same wire. Those pacer spikes are a lot smaller because the distance between the two electrodes are smaller, right?
So how does that work? They put the whole electrode down in the heart like that. How does that work with not getting backflow through the valve? The valve can't. I'm sorry, I totally missed that.
You just not paying attention at all.
Probably not.
Thanks, Chris.
I apologize. Matt was talking.
So, as we already stated, sometimes these valves are often already crappy in like CHF patients or whatever. If it's in a relatively healthy patient and the valves were okay and causing good stoppage of that regurgitation, I mean, the valves are not completely rigid. So they'll kind of form around that catheter when they're in that closed state. So there's still a little bit of regurgitation around that catheter lead, but it's pretty minimal. So it doesn't have as much of an effect as you would think.
Do those valves still work the same?
What do you mean, like when they leak?
Can you tell if it's going to be unipolar or bipolar by the like 5-letter like designation?
Yeah. So the 5-letter designation code will tell you exactly what kind of pacemaker it is. But you can tell on the rhythm strip or on the EKG as well, depending on how big that spike is. Because if it's a unipolar and the positive electrode is the generator and the negative electrode's all the way in the tip, there's a longer distance between the two, so you get a huge spike on the EKG or on the lead. So you guys have you seen pacer spikes on a lead or on an EKG? Well, I'll show you some examples in this, but the pacer spike will be a lot bigger in a unipolar. So if you see a huge pacer spike, you're like, oh, that's a unipolar lead. Little small pacer spike, it's a bipolar lead. So these pacemakers are at a regular rate, right? They're just preset. So there are different kinds of pacemakers. There are sensing pacemakers and the non-sensing. We'll talk about those. But the ones that don't sense sometimes can compete. If certain medication is given and their SA node for whatever reason starts to climb, it can compete with the pacemaker, and then both of them are going off. You got this tachycardic rhythm because the pacemaker is not stopping, even though the regular heart is still conducting. All right, those kind of pacemakers are kind of on the outs, obviously, because they're less effective. So demand pacemakers only switch on to the default pace when the SA node fails, right? When it gets too slow. And then the pacemaker's preset rate starts up. And they can be programmed and reprogrammed through, sensing and magnets and whatnot. They don't have to cut the patient back open to reprogram it. They Bluetooth it. No, I don't know if they Bluetooth it, but right.
So with a patient with pacemaker, if they go and try to exercise on their heart rate starts climbing, is that going to?
It can if you don't have a demand pacemaker. If you have a demand pacemaker, the pacemaker will just shut off. All right. So this is what Craig was talking about, 5-letter coding system used to assist in identifying the pacemaker programmed functions. You guys do not need to memorize this chart, but it kind of gives you an idea of the kind of codes that you'll see with patients, different pacemakers. Usually they'll carry around a card with them. They always have the card in their wallet with what kind of pacemaker they have. Inevitably, the patient always, for whatever reason, doesn't have that card with them when they come in with a pacemaker problem. It floors me, but it seems like that's more common than not.
Why don't they just tattoo it on?
And then we have to call the office. It's usually late at night. We have to call whoever's on call for the office, and then calls like the on-call nurse who has to look it up, and it's a big pain in the butt. So single chamber pacemakers, obviously it's only in one chamber, right? Either the atrium or the ventricle. There's only one lead in the heart. So pacing electrode placed in the right atrium. How do you know it's in the atrium?
P-wave.
Because there's a P wave. Good. So this kind of pacemaker is used when there's a problem with the SA or AV junction, right? But the ventricles are doing just fine. Although in this patient, well, it's a pace rhythm, so you don't even know if that's pathologic or not, unless you looked at some different leads. So ventricular pacing. You can see the pacer spikes, right? You got a nice wide QRS. QRS look okay in the atrial pacing. You've got an odd ST segment, but the QRS should be normal unless they've got disease in the ventricle.
So Scarbo's criteria only for ventricular pacemakers, or is it also?
Generally for ventricular paced rhythms, but it can, I mean.
That would vary from this one or not.
Right, absolutely. In an atrial paced rhythm, it will depend on what the QRS looks like. If the QRS is wide, then it's safe to use the Scarbosa criteria.
So in this case, you wouldn't use Scarbosa.
No, you wouldn't use Scarbosa in this
So you're
case.
still calling this the
Unless you had anything old. Obviously, you guys don't in a pre-hospital setting. That's the advantage that I have is I can look up their last EKG if they had one, right? To see if that's something that's normal with them or not. So this pacemaker spike looks like what?
Ventricular.
Yeah, it looks like a PVC or some kind of ectopic beat, right? All right, dual chamber pacemaker paces both atrium and the ventricle. So 2 lead, one is in the atrium, one's in the ventricle, right? So you get spikes on both. So the dual chamber, really the point is to try to get the atrial kick, try to retain that cardiac output.
So what's going on with that? What's the huge?
The huge spike?
Yeah, is that the QRS?
S, you mean the S?
Where are you talking about the S wave, or are you talking about the spike before the QRS? Which one? This one?
Ginormous S wave. Why is it
Ginormous S wave? Depends on which lead it is. It might be. I mean, you will commonly see pretty big waves with ventricular paced rhythms. It's a good question. Let's see. Let's think about this for a second. It's depolarizing the ventricle. You've got the 12 lead EKG on there. It's giving you a large deflection. I think you will have that large spike because of the placement of the leads in the heart, because it changes how that heart is depolarized depending on where the lead is, right? Because if you're getting stimulus at the apex of the heart, you're going to have a much different spike than if you're getting a stimulus through the conduction system, right?
pretty much pump indefinitely as long as you keep in blood flow good.
Yeah. Now, indefinitely, I mean, there is an age limit to the cardiac cells, to those muscle cells. So it's not like you could keep a heart going for, 2 lifetimes or whatever. There's an endpoint, but maybe someday we'll figure out the oxidative process of aging and try to stop it or reverse it or whatever. I don't see that happening. All right, so dual chamber pacemakers are often called the DDD pacemakers. Both atrium and ventricle, both chambers are sensed, and so they're also, both of them are triggered. So transcutaneous pacing, obviously it's effective, it's quick, it's safe, it's the least invasive for the patient. It's indicated with significant bradycardia. Hey, where are you going?
Shit, I didn't know that was an option.
It's definitely an option. All right. So oftentimes you can use transcutaneous pacing as kind of a bridge as you're trying to figure out what the underlying cause is, right? Now, it might not be absolutely effective if you haven't treated the underlying cause, but because you won't get capture every time, but it certainly is better than nothing, right? Because medically, it's takes a little while to correct something with medications, right? It's not immediate, so you can use transcutaneous as kind of a bridge. So the procedure, the same guy, a little bit overweight. He's getting the rundown. So putting the pads on, that's really poor placement of those pads, in my opinion.
Again, you want them front and back, is that what you were saying?
Or at least more posterior.
Put that lateral pad more posterior.
Yeah, so that you're squeezing that heart.
So we're basically still want that same axis, right? You don't want it to just be like straight through.
Right. All right, so you hit, instead of the charge button, right? You don't want to defibrillate somebody that you want to pace. They might still be somewhat awake. That'd be really bad. You hit the synchronize button. You guys have a synchronize button on your monitors as well, right? Mm-hmm. Synchronize button, and then you can wait a couple of seconds and you'll start to see there's little ticks or little spikes on every QRS complex where it's sensing every single QRS of the patient. The current, you push the current, and that's after you synchronize, and then you designate the rate that you want it to go at, your default rate for your pacing, right? So you can, whatever the patient's normal is, or you think their normal is, or what they can handle, you can put it at 60, you can put it at 70, you can put it at 80 if you wanted to. I would stay probably a little bit on the lower side and then see how it goes. And if the patient still needs a little bit more, you can always bump up the rate after you got it going. All right. So yeah, you're designating the rate. It usually should be anywhere between 60 and 80. You generally don't want to go above 80. So after you've got the rate, then you can start it, right? You can start the pacemaker, and then you increase the current after you've already started it. So it's starting to give current at the rate that you set it. But if you want to slowly increase the current, it usually sets the default current fairly low, and the patient probably won't even feel it initially if they were awake. And then you increase the current until you get what's called capture. All right? Once you get capture, that is when you actually see on the monitor a spike followed by a QRS, right? A contraction. Then you can verify that by feeling the patient's pulse And if you're feeling a pulse, then you've got capture. That heart is beating at that rate that you set it to. Okay? You want to do the current at the threshold. And that was one of those key terms at the very beginning. But what do you think the threshold is? Threshold is the minimum amount of current required for capture. Okay? So you're increasing the current, and you don't want to necessarily do that super slow in a patient that's unstable, right? So you're kind of cruising up with the current, and as soon as you start to see capture, feel a pulse, then you can even hit it down a couple of times until it goes away, and then bump it up 2. So you want it 2, milliamps above the threshold. All right, the minimum amount of current to have capture. All right.
You have to constantly watch out to make sure something doesn't change.
Yeah. You certainly want to keep an eye on it. Right. Set your monitor to, like 5 beats below what you set your pacing is, so that if it starts going below, you'll know right away. It'll start beeping at you. Right. You can set your monitor to whatever rate you want it to alarm at. So it's kind of a safe, so that you don't have to sit there and stare at the lead the whole time you're transporting and ignore other things that you need to do. You can kind of set the monitor at whatever rate you want it to alarm at. And you can set a minimum and a higher one. And if it starts alarming at a higher rate than what you set it at, then what's happening? Yeah, their heart's taking over. Or adding to. All right.
So when you ever have electrical capture without capture, mechanical capture, we should know those to be within the same range.
So you're asking, are you going to have electrical capture, meaning you see a QRS,
Yeah, but you don't
it's
have
being
to-
conducted, but you don't have
Yeah.
flow. You don't have a pulse. Yeah, that can happen.
And so that just continue increasing the milliamps. Do you just say, well, I guess we're going to start
Yeah, not CPR. You could try increasing the current and just be like, well, maybe the thresholds change, or maybe the disease is progressing and it requires more current, and you could bump up the current and see what happens. But you don't want to keep the patient pulseless for too long, right? So restart CPR, because likely what's happening is that there's too much dead muscle, that even though the current's working, the muscle's not.
Are life backs a demand type pacer?
Yes.
Okay.
Well, no, they're not. They're not. They're fixed, so they are not demand. Demand is the inserted internal pacemakers. So yours are not demand pacemakers. You guys control the rate. All right. Let's see. We talked about that. Pacemaker spike. It's going to cause QRS complex wide. QRS in a broad T wave. Once you get capture. I don't know why this is procedure again. Anyway. All right. Talks about threshold. And we talked about this. Okay. All right. So limitations with your transcutaneous pacers. Obviously, they can hurt if the patient wakes up. And it will vary with the current given and the kind of device that is used. There can be failure of your pacemaker, right? Transcutaneous pacemaker. Your leads could be bad. Your pads could be bad. There could be a malfunction in just that aspect of your monitor, and that haven't been checked recently because the patient hadn't been paced for a while, and the pacemaker function just doesn't work. So there can be things that go wrong with it. So you just want to look at your monitor and make sure that you're seeing and feeling what should be happening. If the pacemaker fails, obviously you're going to get symptoms that they had in the first place. I mean, this just goes like what I talked about. Batteries fail, loose wires, broken wires. There can be electromagnetic interference if you're too close to an MRI machine or whatever. You can have failure of the pacers. So patients can code when they're in an MRI, right? You guys aren't called, but the hospital staff is, and you need to get the patient away from the MRI machine if you need to use electricity.
That's that. But like I remember some of the earlier pacemakers, like they didn't want to be anywhere.
Right, they couldn't go in the MRI. Right. There are some pacemakers that you can still get an MRI, but as a general rule, if a patient has a pacemaker, they don't get an MRI. What's that? They can get CT scans, but they just can't get an MRI. And I mean, sometimes it depends on how sick the patient is, what you need to know, and what the underlying reason was that they got the pacemaker. Because if they got the pacemaker because they were, had a type 2 AV block, but would still have some function, like if there was a high type 2 AV block, and still had some function, maybe you might want to risk the MRI and just reset the pacemaker when they're out. I don't know. It's a lesser of two evils, right? Because it works differently. A CT scan is basically just hundreds of slices of an X-ray, right, in a certain plane, whereas an MRI is magnetic. So it's an electric impulse. It actually turns all of the hydrogen ions in your body to a certain direction, and that's when it can sense like density and space of the hydrogen ions and give you different tissues, and that's how a MRI machine works. So it's magnetic and electric, so it'll interfere with the pacemaker. All right, so capture, one of those key terms, successful depolarization. That's basically what it is. All right, failure is inability to have depolarization. So recognized on the EKG as you see the pacer spikes, but there's no complex, right? It's failure to capture. Sometimes when you're getting close to the right amps, it'll do this. You increase the amps a little bit, and you start getting capture and all. Failure to capture, all those same stuff. So in a internal pacemaker, you can not get capture if there's scar tissue built up at that tip. Like if it's dug a little bit too deep, the body responded a certain way, and there's a bunch of scar tissue, it might not be working as well. All right. Possible interventions. If for a transcutaneous pacer, you can reposition the patient. You can increase the output or the amps. You can check the battery. You can reposition the leads. Or if transcutaneous pacing just doesn't work, because the patient's too big or whatever, and they need an internal pacer. They just need surgery. So sensitivity is the extent in which the pacemaker recognizes the conduction system of the heart itself. So that's sensing. So when you're transcutaneously pacing and you're seeing those little tick marks on the QRS complex, it's sensing, right? So it's the ability to sense each of those beats and sense the internal conduction. Let's see. Oh, this is just under sensing. All right. So under sensing, obviously, it's just not sensing the conduction system well, and it's throwing spikes at the wrong time. Causes, all the same that we talked about. Can be a reason. It can be because of the equipment that you're using, or it can be because of disease in the patient. All right. Failure to sense. We talked about that for interventions. Increase sensitivity, replace battery, change the leads. Oversensing. So an atrial sensor might inappropriately sense a ventricle as atrium and create too many spikes too often. You can get, like I said, that can happen with an MRI machine, and apparently it can happen if you're too close to a arc welding equipment. So if somebody's a welder, they shouldn't have a pacemaker and continue to weld. All right. That's not right. Pacing, possible complications. So all of this stuff we talked about a little bit. Transcutaneous pacing. It can cause patients to scoff, cause burns. You can have interference, tissue damage, and like you guys were saying, the threshold can change. You might have to adjust the amps that you're giving. All of these things can be complications of it. And then complications of permanent pacing. And that's usually with implantation, which I don't know why you guys would need to know that. So long-term complications of the permanent pacing. Things that you guys certainly could be called for, that generator that's put in, they can get infected. They do get infected. And if they do get infected, there's nothing that's going to fix that other than pulling it out. Antibiotics won't do it if there's a foreign body that remains. Electrodes can be displaced. They can go through the heart tissue over time. The heart can dilate and distend with CHF patients, and then the lead's not in the right place anymore. You can have a break in the wire, all sorts of stuff that can happen with that. So when you're looking at somebody that has a paced rhythm, you're looking at the P-waves. If the P-waves present at what rate? The QRS complex is present at what rate? And then you want to evaluate each interval. You can use the calipers. You can use your fingers. Sometimes what I do is it's a quick method if you don't have your calipers present all the time, which when you're working, you might not. And then if there's a ventricular activity, obviously you determine what the rate and regularity of that is. Escape interval, it means the patient's own rhythm can show up and there might not be a pacer spike. And you can compare that to the paced interval. I think the dead giveaway is that there's no pacer spike, right? So you can identify all of these things on the EKG or the rhythm strip, depending on what you're seeing. Failure to capture, failure to sense, oversensing, failure to pace. Questions on pacemakers? You guys are just done.
Was that August?
Your willpower has been used up. Hey, I tried to talk to Gary and Doug about this on test days, but you guys just have too much material that needs to be fit in. There's no way around it.
Just the good cop, bad cop thing.
Yeah, a little bit. But this program was set in place way before I got here. I just agree and go with it. Change stuff as I need to. The results are what we're going for, right? Even though it's super, super painful during, the result is always very, very positive.
We're going for is excruciating.
Excruciating, maybe. Just imagine if you had all of these subjects and you were tested on it, and then right after that test, you had to go to another test on different subjects. Then right after that test, you have to go to and take another test on different subjects, and that happens every week. You're taking physiology, EKGs, everything at the same time, and then they're all tested on the same day.
Talk about medical school.
Yeah, I'm talking
That's why none of us are doctors.
This is about as far as we're gonna get.
Let's be real here. If you us want to be doctors, we would be sitting in this room.
Craig.
Gee, I want to.
No, it's all about
He's gonna be a doctor.
it's all about effort. You get out what you put in. Anybody can be a doctor if they put the time in.
Do you think money has anything to do with it?
I'm telling you, and not all doctors are the same. They might study and they might know everything in that book, but they're still piss poor doctors when they get out and use it in real life. And some of them can pass the test, but they're still dumb as rocks. So anybody can do it. Not everybody's going to be good at it.
Is this the one that Dr.